and I hope everybody online is still with us. It's the second part of our event today on the occasion of the International Nurses Day. And the idea was that we used the book launch, actually, Anne-Marie Rafferty's book on how to strengthen health systems through nursing, to discuss what are nurses and how does the nursing profession support health system transformation. And we already have a quite lively and interesting input from Anne-Marie Rafferty, Wendy, and Maggie. Maggie, unfortunately, because of the strike, she had to go very early today to the airport to catch her plane, so she apologizes. In addition to you two, we have a couple of additional panelists. And first of all, here on my left, it's Rachel Greenlee, currently at LSHTM. You are actually also a nurse. And Rachel was asked to join us because she has been extremely instrumental writing up and researching work on the magnet hospitals. It was an EU-funded project, and you are the author of a policy brief thinking about, how can we actually improve working conditions, organizational and management issues in hospitals, to improve retention and quality of work, actually. Then we have Lisa Baldini. That's the first non-nurse actually here on our panel. And Lisa Baldini is the consortium lead of a Joint Action Heroes, which is focusing on recruitment and retention. And if I may say so, it's a quite big and quite lively joint action. Joint action is a way of working together between the member states and the European Commission. And you have almost all the countries in it in a way. 19. Well, that's quite a lot still. And they are very active. There's a community of practice, actually, which is really, really very useful, I think. And also a couple of publications were coming from you, some policy briefs, one on recruitment and retention, one on methods, and one on institutionalizing it. Next is Federica Magheri. Federica, you're not a nurse either, are you? Federica is the director of the European Health Management Association, and we have asked to join her because she's the consortium lead of the Be Well project, a project under the Skills Pact, which is looking into upskilling, reskilling of health workers with a focus on digital skills, which we all need, and green skills, which is addressing one of the big crises we are facing at the moment. And you had last week, actually, your final conference.
Indeed, with a lot of people that are here, and I'm certain online. So that was a good conclusion.
And at the far end of the panel is my dear colleague, again, a non-nurse, actually. You're an economist by training, aren't you, Gemma? And Gemma has been involved.
Oh, yeah, don't hold it against me.
And Gemma has been involved in almost all of the projects and been writing policy briefs, special issues, scientific articles. And usually, when I ask her a question, she starts with Matthias. It's a good question, but at the danger that I derail your facilitation, I have to answer something else. But before we start, we were thinking about running this panel in three steps, and for each of the steps we have with Anne-Marie defined a kind of dilemma, something which is really bothering it, and the first dilemma is actually the future of health systems is nursing. I mean, we heard so many good things about the general nurses, what they already can do. We heard from Wendy, moving into advanced practice nurses, consultant nurses, working in different settings, actually, and also be careful not to set up too many barriers between the different specializations, actually, but try to have some sort of unity in the professions. So we heard already, and we see, supporting health systems transformations to new models of care, integrated care, population-based care, primary care, you name it, nurses will have a big role. But then on the other hand, we have big issues with retention. We have issues with an educational system which is not quite there yet. We are losing people. We have difficulties of recruiting. So how do we deal with this? How do we move forward? Not each of you needs to answer in great length to all the questions. Just give us a little bit of an input. And may I start with you, Rachel?
Thank you, Matthias. And it is a great pleasure to be here alongside such incredible colleagues. But as much as the question and the dilemma looks to address the future of healthcare as nursing, we also have to look into the past, and the more immediate past being COVID-19. The workforce that was working predominantly before COVID-19 is not the same workforce that we've seen come out of it. And so repositioning nursing to be the priority, to be the focus, is largely where a lot of our emphasis is coming from, and we see this in the evidence from the Magnet for Europe trial, from the MENS survey, from the book, is that the solution's already known. The political will needs to match that solution. And so we can have enough if we reposition nurses to be the valued profession that we know them to be. We've seen today just how much a nurse does, all of the skills and all of the organizations and different sectors that are chomping at the bit to take those skills, that nurses possess. But we need to be thinking about nurses as the critical infrastructure that they are, and to put the value and the emphasis, the foundational support, the organizational support behind those nurses. Nurses alone can't be, pulling all of the weight. That they need to have institutions and political will behind them.
Thank you so much. So can I still come back to this? I mean, you've done all this work for the Magnet Hospital, and the idea was to improve the working conditions, the organizational setup, and the managerial stuff. Why hospitals are not doing it by themselves, actually?
Hospitals, the desire, the intention, I think, is there, but it's incredibly difficult to reorganize and restructure, as we know, in the middle of acute crises, and hospitals are working really to the brink of their capacity. And so what we saw with Magnet for Europe, what a beautiful example was the peer support, the twinning element of just showcasing and modeling what can be done. And so as Anne-Marie mentioned, a lot of this work is still going forward now on a voluntary basis. And it's not because there isn't, money to be shifted around, but it's that there's a lot of desire and emphasis from the workforce, from the institution itself, to participate alongside someone else to see what the capability and capacity can be. And so a lot of the interventions that we talked about leadership, we talked about structural empowerment, we talked about putting money behind the workforce, but also providing them something to look forward to. So showing what's capable, providing the educational pathways to get there, but also the leader and mentorship to keep people progressing and moving forward. And so I don't believe that it's hospitals don't have the capability to do it. It's that if you haven't been shown or modeled the way, it's incredibly difficult to then move forward.
Can I challenge you a little bit on this one? Because for me, sometimes it occurs to be a cynical decision of the management. Either we invest and we do things differently, or we keep going like this, and then, okay, we lose some, but we re-recruit, or we have a little less stuff and we make better profit, actually, because we can retain more money. Is that sometimes a managerial decision, to have bad working conditions?
A managerial decision to have bad working conditions. I don't think anyone wants to have bad working conditions, because at a certain point, the manager is going to be influenced by those bad working conditions. You're always going to be faced with somebody in your chair complaining about something. But I think that we repeat what we know to be easy, or the decisions that are consistently happening. And so, no, I don't believe that managers don't have the backs of nurses. I think that there's not enough representation of nurses who have been on the floor to represent those management decisions or potentially lead those managers.
Thank you so much, Rachel. But I saw Federica shaking her head, probably in consent or in...
No, I mean, meaning that if that's a managerial decision, I would define it a short-sighted managerial decision to not invest or, let's say, maintain bad working condition. Because if I reflect on the concept of investment, not investing, it is a choice. It's not a non-choice. It is a choice. It's just a negative choice. And I think that not investing, it just shifts the cost somewhere else. So you're clearly not putting money into a certain area, but then the cost appears somewhere else because you're losing people. And it may be like we're recruiting someone else, but recruiting is not that easy, especially if you don't have a pool to recruit from. So that's a completely different a different area. You have turnover, so this means that you have to invest time in training the people as they enter back into the work, not because they don't know how to do the profession, but because they need to learn the environment, they need to learn the culture. So this is, again, you are maybe saving money somewhere else, but then you are spending it elsewhere. And then, of course, there are inefficiencies because new people are not as efficient as other people that, have worked in the profession or in that specific organization for longer. So all of these, it's not a saving. I think it's just a shifting of the cost in a different area.
Who's paying then the bill if it's a shifting of the costs?
That's a great question that I don't have an answer to. You're being very confrontational.
Raising your hand, please.
I think it goes back to, I mentioned earlier, that if you get nurse staffing correct, so nurses reduce harm, and we need to get policymakers, commissioners, governments to rethink a workforce planning for nurses and not think of it as how much is it going to cost, but how much is it going to save? And that's what we need the key message to be.
But isn't it also about the patients actually? Because of course you mentioned the safety, but it's also the quality. It's access, I guess, and to some extent, certainly the patient experience.
Absolutely. I mean, that's where we see from advanced practice nursing, patients want to see the right person first, and they don't want to see lots of different people. They want holistic care, and that's what we give as nurses. So for patients, it's better, but the health systems is better. What we see for nurses, sometimes we're our own worst enemy. Today's International Nurses Day, and we have to shout out how wonderful nursing is. If you ask a patient, they want to feel safe, and usually they'll say that the nurse was the person who kept their care together and coordinated the care. We know that's the great benefit of nurses, that they are the coordinator of care.
But I think I can figure it's also for many nurses a big challenge, and it's a huge ambition. We are talking about nurses almost indiscriminately, but they are probably very different people in the profession which have very different ambitions. And some of them, I don't say they want to be left alone, but they want to have a very discrete area of action. How do you deal with that?
I think we need to give them options. And I think, I've been a nurse for 37 years. Nurses, I love the profession, but the new generation of nurses aren't going to be like me. They want to have variety as they go across career. Nursing is unique. You can be in nursing. You could be in nursing now for the next 40 years, and you could have a clinical part of your career, a leadership, a research, and an education. You could go into different settings. What we need them to show is, one, we need to make it easy to do that. We need to have that common language, but we also need to have the frameworks and the way to make that happen. And like we said earlier, if they move country and migrate, we also want to make that easier as well, because ultimately that's better for patients. Patients won't want nurses that come into the career for 2-3 years and leave. It's better for the patient as well.
Thank you so much. Anne-Marie, you wanted to come on board on this one.
Yeah, I was just thinking about, you mentioned, Matthias, some people wanting to work out and carve out a space for themselves. And it's just a point really that if we talk solely about nurses, we're missing the team. And, healthcare is delivered by teams. So it's, where does nursing fit and flex within the broader multidisciplinary team? And, the way things are playing out politically, and Wendy's well versed on this as well. At the moment we have a debate in the UK where the British Medical Association is attacking advanced clinical practitioners and saying that they are bad news for patients because they are less safe. They are not practicing in safe ways. But we carried out some research a few years ago that looked at this, relationship between autonomy and team working, and in fact found, rather than seeing it as this kind of either or binary, that actually autonomy is essential for teams to be successful. You've got to feel that level of professional competence and confidence. It all makes, good sense for you to operate in a team, which has always got different elements. It's got, an independent, but it's got an interdependent as well as a dependent kind of set of functions. So I'm just saying, let's forget the team in all of
Thank you so much, Anne-Marie Rafferty. Lisa, I forgot to mention, you're not just the consortium lead of the joint action. I mean, you're working for Agenas, and in this capacity, you are involved in other projects, TSI, and very much into Italian health systems reform. And I think you wanted to share some firsthand experience actually from policymaking in your country.
Yes, thank you very much, Matthias. And sorry for my voice today. Okay, I want to bring your attention to the speech of our Minister of Health just 2 hours ago, that we are looking for more nurses in our healthcare system, because in Italy it is the main problem in the healthcare sector that we have. So we estimate that we are losing by 2034 78,000 nurses, and we cannot know how to find them. So, you have to know that it's true that we are losing also doctors. So we are losing both doctor and nurses, but there is a very big difference, because we are losing doctor, but there is right now a very high demand from people to become doctors. On the contrary, we are losing nurses, and there are no more people that want to become nurse. So all the nurses that we are going to lose, they will not be replaced. So I want to inform you that one of our most developed region in Italy, which is Veneto region, is going to implement 2 concrete measures to face this problem. First of all, Veneto region has just decided last year to give a voucher to the new enrolled student of nurses, to the people that want to become nurse, a voucher of 1,000 euros per year for the 3 years that they have to study. And this is to attract more people in this health professional. And secondly, it's very important. The second one, it is they have implemented a new mobility program. So all the health professionals, in particular nurses, are able now to move among all the healthcare organizations within the region. And in order to facilitate they want to balance the work-life conditions. So nurses, for example, can work closer to their home, or they can work in the health organization where they prefer. So these are 2 actions that Veneto region is trying to implement. It's just a test, an experiment to see if something changed, because we know that if we want to change something in our healthcare system, we need policies. We have to open a dialogue between the technical experts and the policy level. And
you're producing the nurses that can hopefully shape the future of our health systems.
Yeah, and also Heroes is an example of this, because if we plan in a better way healthcare professional, it is also a way to reduce burnout, stress, high turnover. So Heroes, it is the only joint action which is active at the European level, cannot be seen just a temporary project on one-off project. But the result of Heroes must be brought also after the end of this joint action. And in fact, in 2 months, we will have the result of this project, and we are struggling because we want the results to live also after the end of Heroes.
Very good. And there are a couple of policy briefs coming from Heroes, which will keep the messages and the achievements secure. Gemma, please come on board.
So I think Rachel started this by talking about the past. So I think maybe I'll talk about the future, to go sort of like long term. So I was reading today the OECD. So I don't know if anyone knows the PISA survey, which is the OECD program for international student assessment. So they go around and they do a survey every few years of 15-year-olds to sort of talk about their future career intentions. And I was looking at sort of what these young people were saying about careers in nursing. And actually between 2018 and 2022, the number of 15-year-olds saying they wanted to become a nurse had fallen in over half of OECD countries and many non-OECD countries. And this was 4 times higher than the rate of the decline in the number of students saying they wanted to become doctors. So then I was thinking, we have issues right now. We're going to have even more issues as we go forward, because there's so much competition for careers, you know, in the tech sector, social media, etc. Young people don't necessarily want to become nurses. So there needs to be sort of a long-term thinking to this as well, as how you can get students now to want to be nurses in the future. So I was just thinking, I think a lot of the things have been sort of spoken about already, is to show that nursing is sort of a really flexible career. It's meaningful. It's going to be really quite technological, I think, going forward in the future. These are sort of things that young people would like. It has social impact. And as Baroness Rafferty said at the beginning, it's sustainable. You know, AI is going to replace a lot of jobs. It's probably not going to replace nursing. So this is what needs to be emphasized, I think. Again, it's been raised, we need to sort of show that any financial barriers to training are going to be reduced. Yeah. You know, some countries, the UK, have put in place student fees for nurses in recent years, which is hugely detrimental to people wanting to go in, especially when the career might not be the best paid career going forward.
Take Veneto as an example.
Yes. We need to increase visibility in schools, so exposure to secondary schools. I know in some areas, there's partnerships being set up between hospitals and schools. So nurses go into schools, talk about the career and what can be done, and sort of all of the different paths that can be taken. So I think this is sort of, you know, and then I think the reputation as well in the media went up during COVID, perhaps has declined since. It needs to be sustained. So how can we sort of, as advocates, get sort of positive, you know, displays of nurses in the media? How can we sort of sustain that? You know, how many shows have you seen about doctors on Netflix, which are really positive? Whereas the programs I've seen about nurses on Netflix, they are not positive. Like, how can that be changed? What can people do?
Start with webinars at International Nurses Days. Please, Wendy.
I think that's a really good point, and I think, you know, we do need to get some positive news in on the media as well. I managed to influence the BBC a few years ago. It wasn't one of our big soap operas, but it was a daytime, lunchtime soap opera which had 1 million people watching it every day. A target audience that of people that will probably access health and social care. It was a drama set in a general practice, but they listened to me and we worked with them and we developed a 2-year, so it was on every day for 2 years. And the storyline they had in the background, which they focused on at certain times, was their general practice nurse going through the education, do the master's program to be an advanced practitioner. And they had an entire episode of this nurse having a meltdown when she realised she'd got to get 100% in a maths exam for prescribing, and the doctor saying, well, I only have to get 40%. Things like that, I think, really helped the public. And then just, you mentioned about the young people. We had an event at the Royal College of Nursing last year, and the King came actually, because we have a King's Cadets programme. And it was aimed at young people of about the age that you were talking at. And do you know what they were saying, what they felt nurses did? Did what the doctors said. We were the doctor's assistant. And I think we need to get that out, the diversity and the difference that nursing, you know, makes. We need to be good storytellers to get those messages out.
Thanks a lot, Wendy. You wanted to come in very briefly, 2 very brief comments before we move on?
Yes, and to that point, so I think attracting and recruiting and having these interesting storylines and examples is incredibly important. However, I think in your book, it talks about the leaky bucket analogy of we can recruit, but if we're not retaining, then we're just going to keep, having nurses slip away. And everything that I hear of all the points of data of, are we thinking about how we're demonstrating in schools and things, but we don't know why people are leaving. And this is a large part of the problem is we can have all of these great pathways into expanding practice or moving and shifting, but if we don't know the why as to why people either want to relocate or want to leave entirely, then all of our recruitment efforts will go to waste because it will be short term and not thinking about the longer term building a foundation.
Thanks. But I just think with getting back to the voice issue that, the future will be determined by how influential nurses are, in the organizations in which they work and helping to shape those. But just one point on a positive note, actually, if you get into the right position, nursing can be a very well paid job. Yeah. You get up to senior levels, leadership levels, you're earning over 100, 150, sometimes 200,000. And many nurses become chief executives. Some of them are the most skilled chief executives. They've sustained organizations over many years. So, scratch behind some of the most successful people in healthcare, you might find a nurse.
OECD data shows that many countries actually pay well above the average at same qualification level for nurses. Right. Gemma, very briefly.
Yeah, all I was going to say is just sort of picking up on the point of we don't know why people are leaving. I think to some extent we do in the UK at least, because we do the NHS, well, in England, I should say, we do the NHS staff survey.
Yeah.
I know Scotland and Wales have their own sort of versions of that. But it's a really, because I was trying to write a paper on sort of comparing data across Europe on, intention to leave, why people wanted to leave, what they thought about their job. And it just doesn't exist in many countries. I think it was, England, Wales, Scotland, Ireland had it, the Netherlands. Many other countries don't do these regular staff surveys. So they don't know what is happening to people in their workforce. They don't know if, it's the working conditions causing them to want to leave, whether it's, burnout, violence and harassment, whether they don't like the leadership, et cetera, et cetera. So I think staff surveys can be a really useful tool to find out what is going on in your workforce. And that can help you develop policies to improve retention.
Interestingly enough, I know a couple of countries who do staff services among students or doctors, medical doctors, to find out, whether they really pursue a career as practicing doctors and whether they go into general practice or some specialty. So thank you so much. So that was the first round, on this dilemma that, the future is all yours, but can it work actually? Do we have the nurses for this sort of future? The second one, and we already merged into this discussion, was nursing tasks and roles are becoming even more diverse and sophisticated also, but is the profession still united? And you may say, oh, this is maybe a moot point, very academic. Is it really important? I say it's very important. First of all, self-perception. Am I a nurse or am I something else actually? That's very important. Second, in the governance, look at the doctors, the specialists in many countries fight the general practitioners. You don't want to have this in the nursing profession. You want to have some sort of unity, some understanding, that there's some kind of balancing actually. So some ideas. Wendy and Anne-Marie, you are nodding. We want one of you start? Wendy, you?
This is something I feel passionate about. I'm a nurse, whether I'm not, whether it's across global discussion or in the UK, there's been a lot of discussion about, well, is advanced practice a different profession? No, I personally believe, we are all nurses and we are stronger together. What we need is good career frameworks, levels of practice, language, systems and processes that we all feel part of that profession. What you don't want to do is ever follow a model that's been introduced in England over the last 5 or 6 years. Advanced clinical practitioners, Anne-Marie referred to it earlier. It's been a lot of tension, and the reason it was brought in by our NHS England at the time, and I was part of the group that did the framework, and we did voice our concerns, is that it was to have a framework where advanced practitioners can be across a whole range of professions, and that we had all one framework, which is great. That worked, but what didn't work is having a new title called advanced clinical practitioner, where you didn't value your profession. And the tide is changing now in England, and it's what's fueled the BMA, the British Medical Association's current campaign, because they feel that advanced clinical practitioners are taking doctors' jobs. And what, I personally, value being an advanced nurse. And whatever my job role title has been over the years, I always say, hello, I'm Wendy, I'm an advanced nurse. And I think that's an important point.
So, Wendy, is there a difference? I mean, the advanced nurse is upskilling from a general nurse, but we also have in many, many countries nurses which are below in qualification underneath the general nurse. Is there also the unity, or is it becoming more difficult?
I mean, in the UK, we've introduced the Registered Nursing Associate, which obviously, as a Royal College, we have brought that into our career framework. I think the lessons have been that you need to have those discussions of what the workforce needs to look like, because sometimes you get a government that want to introduce something quite quickly. It might look like a cheaper workforce, but actually it's they're nursing support workers still, are valued nursing support workers, and they don't replace the registered nurses. I think when it comes to cost analysis and the evidence base, we need to really value what it is about being a registered nurse, and whether you're advanced or a consultant or above, you're still a registered nurse. And I think that's the professional identity that we need to keep hold of.
Thank you so much, Wendy. We have a third dilemma which we would like to address, and we still have 10 minutes for the discussion before we go to the chat box and to the questions from the floor. And this is that we all agree, and Wendy, you just emphasized it again, that investment in nurses yields returns. But the countries that most urgently need to invest are often those facing the greatest financial constraints. Gemma, you're an economist. I introduced you as an economist. I think this is really kind of your question. Also, Gemma has written a policy brief, authored a policy brief on investing in the health workforce. Please, Gemma.
Yeah, so I mean, I think there are two parts to this question. I think maybe the first part has been addressed already, sort of talking about the returns that you get from investing in the health workforce, in nurses. So I think often politicians are quite reluctant to invest in retention initiatives because they sort of see the health workforce as doesn't give them anything back economically. So it's just a massive cost, it's not productive, and they just don't want to invest in it. But as we've heard, that's not necessarily the case. So I think there are huge multiplier effects from investing in your health workforce. It's a huge source of employment, an absolutely massive source of employment, especially for women, especially for young people. And, this is a huge boost to your economy. So I think you need to sort of emphasize that point to policymakers to get them to invest in it.
It brings stability during crisis.
It brings stability during crisis. Yeah, we've seen during COVID, I mean, what happened to the countries that were not prepared to meet the COVID crisis? So we did a lot of work in the early stages of COVID, sort of mapping out what countries did to increase surgical capacity of their workforce. Many countries they couldn't cope. It really took a toll on the health workers they had because they just didn't have enough. They didn't have any systems to bring sort of retired people back, etc. quickly. This led to huge, long-lasting damage to the morale, the burnout, etc. of health and care workers, nurses. So that's an issue. So it's sort of, and COVID cost our economies, trillions of dollars. How much could we have saved if our health systems were resilient and we had the right people in place, the right procedures to sort of deal with that? So we need to invest in health workforce. It's a huge part of resilience and preparedness. Also, countries with better health systems are more stable. And if you invest in your health workforce, that helps you improve your health system. Your country becomes actually more stable. I think, were you involved in the book with Scott Greer, looking at the politics of health systems? So that's discussed. We have a book on the website where you can sort of look at that. Healthier populations, again, they're more economically active. They, again, they bring money into your economy. So I think, we've covered a lot of that. But then there is the other half that we can't just keep investing in the health workforce. There's not enough people actually that we need to bring
This is
in
one of the phenomena.
to optimize the performance.
Yes. Ewout and me, we were 2 weeks ago in Norway, and our colleague says, we are failing to really fully deliver on our promises, but we can no longer recruit, not only because of the money, but we don't have the people anymore to recruit from, you know.
Yeah, so
Anne-Marie, you wanted to come in.
Yes, thank you. I mean, the point I was going to make was also that I think we need to be educating our policymakers and politicians, you know, and because what Wendy was talking about, you know, soap operas and the kind of image and the perception of nursing. I mean, that's what one is, you know, if you like, way behind the times. It's sort of locked in maybe the 1950s or the 60s. So we need to really update and develop a new narrative, really, is what's actually required. And that needs significant, you know, imagination. But moving forward, you know, all change happens because there are a bundle of kind of interventions, and you need to intervene at different levels. So we need, you know, we produced a conceptual map in the book about the factors that influence system performance that are nurse related. The trick is, all of them have got to be aligned and working, the moving parts at the same time. And that is just fiendishly difficult to damn well do. But, you know, doggedly, you just got to keep at it. You get a plan and you stick to it and you just keep going. That's what Florence Nightingale did.
Talking about the alignment, you know, of the professions, of the different, you have a microphone anyway. Yeah. Professions. You run the joint action heroes, and very clearly all the countries say they benefit actually from health workforce planning and forecasting, but knowing that there are some planning and forecasting at national level, some at regional level, and very often also at organizational level, you know, and how to align this, you know. And I think you know quite a number of stories from your own country, but also from the joint action about this.
Yes, so we have, as I said before, 19 European countries, and we have 19 different situations. So it's not possible to have just one program, but we have to be very flexible, because it has no sense to put at the same level, for example, a countries which has been planning for 10 years as Norway, Italy, Netherlands, with a country that didn't plan. So, for example, Malta, Greece, it's the first time that they created during years the first model, so it was a success. And for example, I want to bring you the example of Malta because it was a success. They didn't have a model at the beginning of Heroes, and now they were able to implement, to copy the model that is implemented in Netherlands, and they are using it. So it is a success. But I have to say that during the joint action, because Hero is not the first joint action on which I am working on, and I agree with my colleague, because one of the most important weaknesses that I met is that we do very important result. We have a very important result, but the most difficult thing is to create this open dialogue between the technical experts and the policymakers. Mm-hmm. So we have to find a way to involve more and to educate more our policymakers, because it is the key. It is the key for the success.
Federica, I need to come to you now, because we're talking about recruitment and training, and I can see the dollar signs in the eyes of many people, but it's not necessarily always very, very expensive. You know, there's also continuous professional development. And the joint action, the project Be Well was so special, not only because of doing the analysis, the skills metrics, defining the skills, but also translating it into something practical. Maybe you fill us a little bit in, you know, how solutions, or one element of solutions could look like.
Yeah, and let me also go back to the very first question about, do we have the nurses for the future? Because I think it connects very well. It's clearly, we talked about shortages. We know that there is a large shortage, but even if we don't have the numbers, so that is clear. But even if we had the number, or irrespective of the numbers that we don't have, we still have people right now in the profession. And it becomes a question of, do they have the skills that are necessary? Do they have the digital skills for the digitalization of healthcare? Do they have the core competencies or soft skills that support the digitalization, but in general that support the whole system, communication, leadership, collaboration? Care is changing, so that's part of it. And to connect these with BeWell, what we've learned from BeWell is that sure, sometimes investments are expensive, but what we have seen from BeWell is that it's all about the strategic direction of these investments, because we have seen that we can do a lot with relatively small funds. We can invest in more modular and flexible training. So we can invest in embedding learning into working hours instead of having to redirect nurses or any other health and care professionals into doing training. So it's not just about how much we invest, but also about how strategically we invest.
On this very positive note, I would like to invite everybody in the room, but also the people online with comments and questions. Bear.
Great. Thank you, Bear Owen, Executive Director of European Specialist Nurses Organization. I wonder, and I come back to your input on Rachel. When mentioning hospitals, we see in Europe a big division between the public domain and the private domain. But the private domain is mostly paid by private equity, and it is a profitable character just to make profit and sell them again. While the most fragile point is the public domain. That's where the innovation comes, but also that's also where the nurses are trained, and if you're looking at the private, the education, the career progression is the least invested in that domain. So can you also maybe respond a bit on this when touching your organization, if you also see a division between this while addressing this shortage?
So the profession may be united, but the system is divided. Let's collect a couple of questions. Eva, please.
Yeah, I have a question too. Hearing a lot about education and training, really important. And I was wondering, in these multidisciplinary teams, we're also working with people who are not nurses and doctors and other health professionals. What are your thoughts on, for example, interprofessional training? Is that also needed to build more understanding for the nurse profession among other professions as well, and whether you see good examples, perhaps?
So now a third question.
Elena Val, International Organization for Migration. Reflecting on your question, I wanted also to add, what's your experience about interdisciplinary collaborations? Because indeed, referring to the joint action and to this economics aspect, is not only the Ministry of Health, is not only the Ministry of Finance. You need to work on a system. What's your experience and which are the challenges? Over.
Okay, so that's a third. It's a variation. You were about professional training, and you were about the collaboration across different sectors, and also on the planning and so. Rachel, you were moving in your seat.
I was fanning myself. It's a bit warm, but it is a good entry point. So thank you very much for the first question around public versus private, and what we're seeing, and I think with Magnet for Europe, it's one of the more novel interventions looking at structural transformation and empowerment and transformational leadership, and we don't have the studies to then look at the public space, what is happening with regards to that, but it is something that we experienced. So I'm from Canada, and we're nursed in Canada for 10 years, and a lot of our nurses were being pulled into the private sector for a variety of reasons. Maybe it was pay, maybe it was, just personal choice, but a lot of the same issues that we're facing with retention in the public sector could be contributing to then what we're seeing, the attractiveness of the public. And so thinking about if there's not opportunity for flexible working, if there's not care and consideration for women being the largest part of the health workforce, if they're family planning or if they're, coming back after re-entry and there's not an easy path, but maybe the public or the private domain then looks a little bit more attractive. So I'd love to see in the future that those aren't at odds with one another, that they're not competing with one another. But at this point, I just think we don't have the data to be able to extrapolate or understand the intricacies between the relationship. I don't think we know what those variables are. But as systems move more toward larger private enterprise, it might be something to consider looking into the future. But to that point, then maybe, or if you want to do it in succession.
Yes, in succession.
Okay.
But one of the things here on the continent, we have plenty of mixed systems, and some of them are actually predominantly private, but under regulation. So it's a regulatory issue, isn't it? Do we have a view on this? No, then no worries. Second, anybody else wants to expand on this one?
Well, I was hoping to hear from an economist on that and what the evidence base actually is.
I can come in a little bit. I mean, this is an issue that we see not just in the nursing profession. We see it all over. Lots of concern. What does it mean? You have privatization, you have private equity, you have different kinds. You have more benign ones, more malign ones, So I think this is one where also the evidence is very mixed, whether it is very negative or not. There is a lot of anecdotal evidence and you can see the mechanism behind it. Institutions loaded with debt and then they take off and you leave an area underserved. This is one that we will stay on. And I think, but indeed, more research is necessary. Not a popular thing to say, but one that we are, as observatory, quite on top of, actually.
Should I say one thing? It's going to set you homework, really. So we, after sort of COVID, we wrote a policy brief. It was led by Barbara McPake, and it was for the 5th Global Forum on Human Resources for Health. And it was thinking about where we can sort of make smart investments in the health workforce. So where could we best put our money? And a lot of actually the things that have just come up in these questions sort of in it. One of them is sort of the divide between the public and private and how you can sort of diminish that or help them work together in more efficient ways. The other is sort of looking at the importance of interprofessional education, and how to best go about improving recruitment, retention, et cetera, et cetera, et cetera. So lots of these issues are sort of covered and some of the evidence is in that policy brief. So I won't go into it all now, but I would sort of recommend going away into reading that brief.
Yeah, I know Barbara from my days at LSHTM as well. It's great to hear her name. Yeah, the IP, the interprofessional education conundrum. I mean, we tend to do it in the pre-registration when, we're all in university together. And because we're a fairly compressed group then, it's easy to access people. It's much more difficult when people are in the workplace. But that's exactly where we need to be focusing and targeting interprofessional education. I mean, there's lots of simulation type support, I think, in many clinical settings, but that really needs to be bumped up, and pumped up in a major way, I think, to really solder those kind of skills in situ and into the workplace.
Wendy, I saw you nodding.
Nodding, yes, no, absolutely. I think I could like to touch on a few of those questions. I totally agree. We need to value that that education and not put. I think sometimes barriers are put up sometimes in policy and sometimes in academic discussions, but in reality, sometimes I see in my clinical practice interprofessional working. If I have in that car you saw me in, if I have a student, it's not actually a student nurse, it's a general practice registrar who I supervise. Now, actually, in that medical world in the UK, they have quite a straightforward model. I get paid extra if I have a doctor that I'm supervising and teaching. If I have a nurse next to me, there's no structure. So I think going back to your question about if you were a patient and you were going to have a chest drain in, whether that be an advanced practitioner working advanced nurse working in an emergency department or an advanced respiratory nurse or a doctor, you'd want them to have the same competence, the same education, the same supervised practice, and the same sign-off that they're competent. For nurses and other allied professionals, we're quite good at doing that. And actually, we don't need to have different systems. We need to collaborate with our medical colleagues. We do it quite well in the UK, or we have done. The current arguments hopefully won't affect that. But I think that's important for a patient, and actually you want it done at the right time. So if the right person is a nurse, then absolutely they should have the skills. And then finally, on investment in nursing, what I don't think we do very well, and we probably don't prioritize it in research, is that return on investment. What does that return on investment mean in nursing? How can we show that if you've got the right amount of workforce, you can make a difference? We know if we're going to have the right workforce, we probably need to double nursing. And we panic and think, well, how are we going to do that with recruitment and retention? If we're going to do that, we need to start now with the toddlers and the young people, because we want to encourage them to be the nurses of the future. We need to think decades ahead to make it happen. I'm a nan, and I'm absolutely astonished at how when any of the toys for my toddler grandson, they're very gender, and his stethoscope set will only be for a doctor, and it's very doctor and nurse even at that very young age. So how are we going to change that?
Thanks a lot. But Elna, I think your question was not really addressed so far. It was a bit of a governance question, if I understand correctly. So because you said that in order to be effective, we need to work across different sectors, like health needs to work with employment, needs to work with education, needs to work with finance, and so on. So we need to have the governance structures and the willingness to collaborate also sometimes across levels, because education is very often a regional thing in Europe. Anybody wants to have a quick go at this one before we turn to the chat box? Yes, please.
Well, very briefly, completely agree. I think that what we've seen with the BWA project is that cross-sectoral collaboration is key. It's important to understand the employer side, the workers or health professional side, education. Clearly, BWA was focused on skills, so far as the collaboration with education was essential. But equally, it was essential to have the collaboration of the social partners, so all the employer side of things, so the world of work. It really is a combination of factor. BWell was also looking at green skills, so clearly there is an environmental component as well. I don't think we can work anymore in isolation for how the world has evolved, and not just the healthcare sector. We really need to break down the silos and really collaborate at multiple levels and across sectors.
Very important, social partners and working across sectors. How about the chat box? Is still somebody there?
Yes. I'll try to summarize very quickly the different reflections on the three different dilemmas, and also raising some of the questions that I didn't manage from the first session. So some participants are reflecting clearly on the need to promote the value of the nursing profession, advocating again and again that it improves patient outcomes. But how do we do this without waiting for the political goodwill? So in times of financial constraint and when competing with the defense sector, and both these points are feeding again into the discussion about needing to educate policymakers, changing the narrative, making the financial case. Then we had a colleague from Ireland who posted about a program that they run at the local university for teenagers to explore nursing as a potential career. And it's very well attended, and they see some of the students that actually then start as student nurses. And concerning the staff exit surveys, someone said that they're often not performed with nurses, so they're not heard and coming to leadership again. Whilst physicians are frequently involved in the planning and management decision-making, they don't see that with nurses. So what is driving this disparity, and what can we do to change it?
Great, but these are more comments actually than really questions, aren't they?
The last one was a question.
Was a question? I didn't see the question mark.
What's driving the disparity, and what can we do to change it between doctors and nurses being represented in leadership positions?
Very quickly, I think we need to, I don't know how this will translate for the European, we need to kick the door down and get around the table. You know, physicians is an expectation. If we see that there's not a nurse around the table, we say why, we volunteer ourselves to be there, and then we speak with evidence and convict and confidence and capability.
And don't forget the patients. Can we have a very quick round, just 1 or 2 sentences, you know, a message coming from this afternoon, you know, on International Nurses Day? What would you like to tell people? Please, Rachel. Please, Rachel, you start.
Let me start us off. I think one point that I probably didn't get a chance to make was just around the notion of those faced with the biggest financial constraints sometimes need the most support in thinking about the future of their nurses, but they have the most to give us in terms of clarity. And when we get clear about what we need to do, and Magnet for Europe showed this, that through leadership empowerment, structural empowerment, leadership, through providing nurses with a vision for their future, it's possible and it doesn't cost a ton of money.
Thanks a lot. So very much about equity. And Anne-Marie, please.
Yeah, I guess my kind of takeaway is that we need to level up and really try to amplify how we engage with policymakers. At the end of the day, everything rests on the Treasury. You know, we can do lots of collaboration, but we have to understand the Treasury kind of mentality, which is always no, default position is no, but building alliances and working with others, it's back to the team in every setting.
Building alliances, especially with the financing. Please, Federica.
Well, for me, I have to say I've been very privileged to be here today. I've learned a lot. And I think that this is the type of dialogue that it's important to have more and in the future, because it's about really reframing or better presenting a different examples of the nursing profession. For me, it was really enlightening and a joy to listen to all of the speakers. So for me, it's about this. It's really giving a new examples, new light to the nurses.
Thank you so much, Federica. Sounds like mission achieved, huh, Anne-Marie? Wendy, please.
I think the clear message is to value nursing. You know, we're the first to moan, and it's difficult, I know, but we're the first to moan. But what we've got to do is value our worth, value that we're that safety critical profession. You know, we are, you know, in majority of countries now, graduates, you know, and the policymakers, you know, if they hear our stories, how you can make change, whether it's a clinical leadership, educational research, you know, really value that. So that's my main message.
Thank you so much, Wendy. Gemma, please.
So I will say, if you want a resilient society, if you want a resilient and prosperous economy, you need to invest in your health systems. Therefore, you need to invest in your health and care workforce, because they're the backbone of your health system. And the nurses is the biggest part of the health workforce. You need to invest in your nursing workforce.
Thank you so much, Gemma. And I think this is a very important point to be made, because we all understand that the resilience, but also health security, is resting very much on the health workers. And as you say, the nurses are the biggest group in it, and probably the one which have the most interesting future. Thank you so much for joining us here in the room in Brussels. Thank you so much for online. We apologize for being late. We apologize for a lot of hiccups caused by not the International Nurses Day, but the general strike in Brussels. Also, for all those who are here, the books got stuck in customs and cannot be released during general strike. So if you want to have a book of the green one, we are more than happy to send you one. Just let us know, and we will take care of it. So thank you so much, and a big applause for our people here at the panel, and also for you for engaging in this debate. Thank you so much. Thanks.